Thank you very much, Dr. Panoff. I'd really like to thank the department both for having us with you guys. It's been an amazing 1+ year working with the service, and really thank you for giving us the opportunity to present our research. I'm going to be presenting my project about multimodality therapy in pediatric AVMs. And this is about a 17-year experience of Dr. Gatan and Dr. Berenstein working through this quite rare pathology. Nothing to disclose for this presentation. So pediatric AVMs are very rare. They constitute only about 3% of all arteriovenous malformations. But that being said, AVMs are the most common cause for pediatric intracranial hemorrhage, constituting 35 to 55% of all bleeds. Pediatric ICH does have a very low overall incidence of 1.4 per 100,000 person years, but it can be devastating with long-lasting morbidity in a kid. Now, due to the long life expectancy of children, the lifetime bleeding risk of an AVM that is diagnosed at the age of 10 is actually calculated at about 95%. So it's very important to recognize that each pediatric AVM is a lifelong disease, and it brings about significant burden to the child and the family. So having an AVM entails the risk of rupture, steal phenomena, seizures, as well as the fear of loss of functional independence. And in a lot of cases, this results in uncertainty and fear that is paralyzing both to the children and the parents. Essentially, once diagnosed with something neurological that doesn't kill you as a child, it changes your sense of health. So we cannot underestimate the fear of living with a live AVM. Now, unfortunately, the literature on pediatric AVMs is currently quite limited. Pediatric AVMs were excluded from Aruba, and there are only a handful of retrospective studies focusing on this age group. And treatment modalities are still quite controversial, with a general focus on ruptured AVMs, where it's easier to justify aggressive surgical management. One very important aspect to consider is also that there are very few centers worldwide that are capable of screening and following each and every child regarding embolization, surgery, and radiosurgery from the moment of diagnosis. And that fact gives our center an advantage because of the seamless integration of endovascular surgical and radiosurgical treatment capabilities. Essentially, Dr. Gatan and Dr. Berenstein have been working together for these years in a true multimodality way, and they both see the patient when diagnosed, and the goal is to start by using the least invasive method to cure it by embolization. And if complete obliteration is deemed impossible by embolization, then they will work together to transition to surgery or radiosurgery. So the result is a true collaborative relationship between endovascular and surgical treatment. What we did for this study was a retrospective case series of children treated for AVMs with Dr. Gatan and Dr. Berenstein throughout both the Mount Sinai system and Columbia previously, dating back to 2003. For the purposes of our study, we only included children that eventually had surgery or radiosurgery for their lesions, with one or more sessions of endovascular embolization, and this was considered an adjunct for this specific study. So our study serves as a real-world count of a 17-year surgical experience with equal consideration and availability of all treatment modalities. In total, we had 50 children that were included in our series with a mean age of 10.6 years and 22 of which were girls. Less than half of our cohort presented with intracranial hemorrhage, with the rest of the AVMs being found due to seizures, focal deficits, or completely incidentally. And this is actually in contrast to previous studies that included a vast majority of ruptured AVMs. The included lesions had a mean diameter of 3.5 centimeters. About half of them were in eloquent cortex, and 40% had deep drainage. Our mean follow-up for our cohort was 5.5 years. And if we assume that these lesions were present at birth, the calculated initial rupture rate was 4.5 per year. Here you can see the Spetzler-Martin Grade distribution for our cohort, with most AVMs being grade 2. Now, endovascular treatment was done for 44 of our 50 patients, with embolization being done as a first treatment modality, usually at the age of presentation. Therefore, the mean age at first endovascular procedure was 10.5 years. For the cohort, 23 of the children had a single embolization, 11 had 2, and 10 had 3 or more, with up to 9 treatment sessions in a single child. And we have to keep in mind, as we mentioned before, all of the included cases eventually had resection or radiosurgery, so complete obliteration was deemed not possible. Here you can see a 14-year-old boy with a Spetzler-Martin Grade 3 AVM before and after embolization of the right pericallosal and posterior lateral choroidal feeders with NBCA and onyx, achieving 80% obliteration of the malformation in a single session. Regarding surgery now, 36 children had their AVM resected surgically. And this was usually done after 1 or more sessions of endovascular embolization, with the mean age at surgery being 12.5 years, and specifically the time from first embolization to resection being 18 months as a mean. Now, all these surgical cases had complete obliteration of the lesion confirmed by postoperative angiogram or MRI, and none of the cases required reoperation. Here we can see the same patient that had embolization for his Spetzler-Martin Grade 3 AVM with 80% obliteration, and he proceeded to have surgery with complete resection of the malformation. And today, after 33 months of follow-up, he is completely intact neurologically and enjoying a normal life. Now, 14 children of our cohort underwent radiosurgery, and all of them were after at least 1 attempt at endovascular treatment. The mean age of radiosurgery was 11.9 years, and here complete obliteration was achieved in 84.6% of cases after a mean of 37.7 months. Two of these children had to undergo a second radiosurgical treatment because of incomplete obliteration. Here we can see an 18-year-old girl with a large left basal ganglia AVM fed by the left anterior choroidal and lateral lenticular striates with deep drainage into the vein of Rosenthal. And this Spetzler-Martin Grade 4 lesion underwent 2 embolizations that achieved partial obliteration, followed by a single session of radiosurgery. And this is a repeat angiogram after 31 months, revealing complete obliteration of the malformation. And here you can see on the left the MRI 10 months after radiosurgery with residual AVM and some edema, and after 48 months on the right showing no residual anymore. And this patient as well has been intact. Here we can see the distribution of surgical and radiosurgical cases among Spetzler-Martin grades, and it's quite obvious that radiosurgery was primarily used for higher grade lesions as expected, but our single grade 5 lesion was actually resected. And here we can see the overall functional outcomes of our cohort. We can see that by the time of last follow-up, almost all children had an MRS of 0 or 1. With just 3 children with MRS of 2, 3 children with MRS of 3, and a single child with MRS of 5. We had no deaths recorded in our cohort, and this is, you can see, a significant improvement from the initial MRS at presentation, which does include both incidental and hemorrhagic lesions. Now, with the limitations of time, I would like to highlight 3 cases that might not be considered microsurgical per se, but underscore our team approach. The first one is a 17-year-old girl who presented with seizures and was offered radiosurgery at another institution. She's from an Orthodox community, and the burden of disease is amplified by the expectation to marry young and the delay such a treatment would necessitate, with the added difficulty of just not addressing her epilepsy. So as you can see, here we have a lesion that sits in the central sulcus and has a compact nidus coming to the surface. With neurophysiological monitoring and adjunctive preoperative embolization, this became a surgical cure and stopped her seizures, allowing her to move on with her life. Now, the reality of taking care of children highlights another set of patients, those with a deeper but accessible nidus, in whom radiosurgery would commonly be recommended, but parental concerns about the consequences of radiation will negate that as a possibility. And here we have a 17-year-old patient who presented with a hemorrhage and transient left hemiparesis, which fully resolved, but mom was adamant that we do not perform radiosurgery. So the patient subsequently underwent surgical resection with no residual on postoperative angiogram, as you can see here. The last case that I would like to highlight is about a boy born with an incidentally found large AVM. The family was living in California and moved their entire lives to New York to get endovascular treatment. And after multiple embolizations, the parents had been adamant about not letting their son know about his own condition. So when he was 16, he had a small rupture into the ventricle that necessitated an EVD placement. And this really served to alert all parties involved that this could not be kept from him anymore. So the patient already had a rupture. He had developed a mild right-sided weakness during his treatment course and had a surgical corridor with encephalomalacia, as well as as all the ACA and PCA feeders had already been obliterated. So it was actually possible to resect it. Currently has a mild right-sided weakness and a right field cut, but he's graduating high school and he's planning his undergraduate studies. So resecting this large lesion really helped with his quality of life, and this is exactly how multimodality therapy can really help achieve excellent outcomes, even for cases that seem exceedingly dangerous at first. So, in summary, we present a case series of 50 pediatric patients treated for arteriovenous malformations with surgery or radiosurgery, with or without adjunctive embolization over a course of 17 years. Obliteration rates were excellent with surgical resection, and they were very good with radiosurgery, which was chosen for lesions that were really difficult to resect. And functional outcomes were excellent across the board. So in conclusion, children have a longer life expectancy, they have a higher AVM rupture risk than adults, and they have great CNS plasticity to facilitate surgical resection or radiosurgery. More than that, psychosocial factors play a great role and can cause severe distress on the patient and family if a known lesion is not dealt with. So in the right hands, pediatric AVMs can be safely and comprehensively removed and treated. And this is not just based on the skill of the individual surgeon or interventionalist, but it's a collaborative effort using each modality in the most appropriate manner. So due to all these factors and the excellent expected outcomes that we see, we advocate for a proactive, comprehensive multimodality approach for every single patient, pediatric AVM patient that we see. And that is what we should try to do. And as a final remark, we have to keep in mind that a pediatric AVM is essentially a chronic disease until it has been comprehensively treated. So thank you very much for your attention. I'd like to especially thank Alyssa and Travis for their help putting all these data together, and Dr. Gatan and Dr. Berenstain for all their years of work in this pathology. I'll take any questions you may have.
Thank you so much, George. So guys, if anything pops up, we can address it. Otherwise, again, excellent work. And we can move on to the next part of the session.
Well, can I ask a quick question? This is Kurt.
Yeah.
Hey, George, great job. Even though I'm a little upset you didn't include me on this paper, I'll still say that it was a great study, and I appreciate your including the individual case stories to kind of highlight the importance of the multimodality treatment. My question is, this is great in New York City where we have all these resources, but what do you tell people who are a young child who lives in rural Mississippi, if they don't have access to this type of care? How would you carry out your recommendations for these patients who don't have access to the same quality of care that we do?
I think that's definitely a big consideration about the geography and how to actually get the proper treatment. My idea about it is that these kinds of lesions, which are quite rare, it's quite hard to have small centers that can comprehensively treat them. So my opinion about it is that most people should be referred to a large center that has everything that needs to be done on a routine basis, and have follow-up with people that can do everything and can consider everything, so that the most appropriate management is instituted. But on the acute phase, I'm sure most treatment centers all over the country can take care of something that happens as a complication or as bleed or anything else that happens. But I do feel that most of these cases should be referred to a large center that has all the capabilities, at least for follow-up.
Can I make a comment here, please?
Please, Dr. Spetzler.
Oh, George, great job, and a great holistic presentation, which I think captures the essence of what patients and families face when they come to us with this problem. I have been particularly impressed by your attention to detail in compiling these data that come from far and wide from basically 3 health systems over the past 17 years. Kurt, I've got a great opportunity for you to be included on the paper, which is to help track down the other 15 to 20 cases that are still missing data, some of whom were treated in my time at Columbia before 2012, when I transitioned to Continuum. So there's ample opportunity for others to get involved in this. And once again, George, fantastic job. Thank you.
Thank you very much, Dr. Rattan. I think there is a question on the chat. I see here, I'm going to read it by Stavros Matsoukas. Since 25% of treated cases were found incidentally, are there currently any thoughts of any type of screening in patients that present with minor symptoms or are asymptomatic at all? And I would say that all kids that come in with neurological symptoms do get a comprehensive workup. And such lesions are mostly found through such workup, but incidental lesions have been mostly found for screening for other causes. I really don't think there would be any reason to scan children as a screening without any symptoms. I don't know if anybody has any other thoughts on that.
I think your incidence is too low to consider doing wide-scale population-based screening, but you could consider it for patients with family histories or other potential risk factors like genetic conditions.
Thank you.
George, one other thing I wanted to add, there's some recent literature, the paper that came out this month, and a couple of other smaller studies in the last few years suggesting that pediatric AVMs recur at a higher rate than adult AVMs. Do you know what our practice is for ongoing follow-up with these patients after complete obliteration of their AVMs?
So from the data that we have put together, all these patients, even after they are completely obliterated, they keep getting followed up in clinic, and I see patients with after years and years to still be followed by Dr. Tan's office. Now, screening them with imaging, from my database, I saw that that happens over a couple of years, and then it's just clinical follow-up. I don't know if Dr. Gatan has any other input on that.
So, can you hear me now?
Yes, sir.
Okay, so the vast majority of patients do not undergo subsequent angiograms, but most of the parents request follow-up MRIs long down the line. So we do not study this with DSA necessarily in years after the initial angio. Perhaps after reading that paper, we might make that argument. But we also have not had late ruptures in the patients who were operated on in 2003 to 2010.
I think it's an interesting point for discussion among the group that we can talk about offline. Well, thanks so much, George.
Thank you very much.
Back. And I think we can move on to Neurocritical Care Conference, but you guys have done great work here, obviously, on the research end and on the clinical side, and we appreciate everything you've done here.
Thank you so much.
Thank you so much. Thank you.